Hit the subscribe button or visit us at auau.auanet.org.
Well, thank you very much, Dr. Cookson and Dr. Gerard, for the opportunity to be part of the course faculty, and to the AUA staff for all the work in helping to organize it. We did have quite a nice session yesterday afternoon, and looking forward to some more engaging interactions today. As mentioned, I'm going to cover the topics of both bone health and radionuclide therapy. Here are my disclosures, again, all in non-muscle invasive bladder cancer, so not relevant for these topics. Our learning objectives are to discuss the specific recommendations within our AUA guidelines for bone health and radionuclide therapy, to be able to then integrate advances in bone health management to patient-specific care plans that are practical for clinic tomorrow, to be able to proactively identify and manage the side effects of the therapeutics used for preventing skeletal-related events in patients with advanced prostate cancer, and to then be able to identify which patients are the best candidates or most appropriate for radionuclide therapy in symptomatic mCRPC. So let's start in the first half of this talk by talking about bone health in advanced prostate cancer, and we'll move in the second part of the talk to radionuclide therapy. When we think about bone health in prostate cancer, there are two relevant issues. There's the issue of bone loss, and there's the issue of bone metastasis. Now, bone loss is relevant to these patients because the median age of patients with advanced prostate cancer is consistent with that population who is at risk for physiologic age-related decrease in bone mineral density that is then accelerated by treatment with androgen deprivation therapy with an increased risk of fracture. At the same time, bone metastasis is a relevant topic because bone is a frequent site, as we'll see, of prostate cancer metastatic disease. Now, when bone metastatic disease develops, the sequelae include pain, hypercalcemia, as well as what are known as skeletal-related events. These include pathologic fractures, spinal cord compression, need for orthopedic surgery or intervention with radiotherapy to the bone. The issue of bone loss here is important for us to understand from a clinical practice standpoint, because these are things that we need to be seeking out in our patient history. What are risk factors for bone loss? Older patient age, prior fracture history, parental fracture history, low body weight, and then behavioral modifying factors, as we'll see, smoking and alcohol consumption. In addition, for prostate cancer patients, treatment with androgen deprivation therapy, steroid therapy, radiation therapy, and then important to be aware of other medications that may interact as well. This was a multivariable analysis published in New England Journal of Medicine that really quantifies, as you can see using SEER Medicare data, the association and dose dependence of androgen deprivation therapy with patients' risk of subsequent fracture and fracture requiring hospitalization. Follow-up studies showing the impact on overall survival of patients who experience a fracture with prostate cancer while on androgen deprivation therapy. You can see significantly lower overall survival among these patients. So, what should be the general approach to a bone loss risk assessment for men with advanced prostate cancer who are initiating androgen deprivation therapy? These patients should have a baseline risk assessment with blood work, calcium, creatinine, and vitamin D, and then a baseline bone density, also known as DEXA scan, that quantitates the presence of osteopenia and osteoporosis. For patients on androgen deprivation therapy, we generally repeat these tests at 1 year and then at every 1 to 2 year intervals thereafter while they remain on androgen deprivation therapy. In terms of looking at our AUA guidelines to understand what are the recommendations for bone health in patients with advanced prostate cancer initiating androgen deprivation therapy, again, we've been coming back to these over and over as they were updated in 2020. Clinicians should discuss the risk of osteoporosis when androgen deprivation therapy is being initiated and assess the risk of fracture, bone density scan. Recommend preventative treatment with supplemental calcium, vitamin D, and then smoking cessation, regular weight-bearing exercise when androgen deprivation therapy is being initiated. What about calcium and vitamin D? Based on our guidelines, calcium dose 1,000 to 1,200 milligrams daily, vitamin D 1,000 units daily. These are very consistent with our national osteoporosis guidelines for all men over the age of 50. Vitamin D meta-analysis has been demonstrated to decrease the relative risk of hip fracture as well as non-vertebral fracture significantly in both men and women over the age of 60. Some important points about administering calcium: better absorption when given in divided doses. The formulary calcium citrate absorbs better than calcium carbonate. Important to know that calcium alone supplementation does not prevent bone mineral density loss, has to be given with vitamin D. Now, there are some conflicting data about calcium and cardiovascular disease, calcium and fatal prostate cancer risk, but again, particularly when patients are on androgen deprivation therapy, and then, as we will talk about, bone modifying agents, that relative risk-benefit ratio still favors supplementation with calcium and vitamin D. Again, coming back to our AUA guidelines, now moving from just initiating ADT, where it was calcium, vitamin D, and behavioral modification, bone health recommendations in patients with metastatic CRPC. AUA guidelines state that a bone protective agent, such as denosumab or zoledronic acid, should be prescribed for mCRPC patients with bone metastatic disease to then prevent skeletal-related events. So very careful to understand what the guidelines recommend. It's that we should be prescribing a bone protective agent when bone mets in mCRPC are present. And this is very consistent as well with the NCCN guidelines. So let's talk about each of these agents. Zoledronic acid is in the bisphosphonate class of medication. It functions by inhibiting bone resorption. It is given as an IV infusion. And in the setting of bone metastatic CRPC, the dosing interval is every 4 weeks. We'll come back to what that changes to in other disease states. It's in fact the only bisphosphonate been demonstrated to have a benefit in mCRPC, decreasing skeletal-related events. Very important when you're giving zoledronic acid to understand its toxicity profile. Osteonecrosis of the jaw, get a dental exam first. Hypocalcemia, again, emphasizing the importance of calcium supplementation and monitoring. Nephrotoxicity, I'll show you how we can dose adjust it for creatinine clearance, and it can be associated with a sort of acute phase flu-like symptoms. This acute phase reaction of fever, myalgias, arthralgias occurs in about a quarter of patients, typically with the first dose, typically in the first day. Management here is conservative, and this typically is self-resolving. In terms of renal toxicity, the importance of dose adjusting, and this slide is in your handout for reference, how the dose of zoledronic acid may be modified pending a patient's baseline creatinine clearance. Moving to denosumab, denosumab is a human monoclonal antibody against the rank ligand. It inhibits osteoclast-mediated bone destruction. As opposed to zoledronic acid, which was IV, denosumab is sub-Q, but again, bone metastatic CRPC given every 4 weeks. Toxicities to be particularly aware of, again, osteonecrosis of the jaw, hypocalcemia. This term osteonecrosis of the jaw, what does it mean? It essentially means a non-healing bone ulcer in an area of non-metastatic disease. So it's exposed maxillofacial bone from an ulcer with no evidence of healing after generally about 6 weeks. These patients should be referred promptly for dental evaluation and care. Now, what should we know about risk factors for osteonecrosis of the jaw? Presence of cancer, radiation therapy, corticosteroid use. Very importantly, poor dental hygiene, active dental work, poor fitting dentures. So these are things to be aware of, which is why we get a dental exam first. We avoid elective dental procedures in patients on therapy. Other potentially modifiable risk factors: alcohol and tobacco use, coagulopathy, and infection, along with bisphosphonate and denosumab therapy. How do we minimize the risk? Oral hygiene is the best prophylaxis. Limit alcohol and tobacco use, get a baseline dental exam, and take care of elective dental procedures, particularly extraction. Every 6-month dental visits during treatment. Avoid extraction whenever possible. Warn patients about ill-fitting dentures. If a patient develops osteonecrosis of the jaw while on zoledronic acid or denosumab, the general recommendation is to withhold further therapy until that site has healed. Generally, the treatment is conservative with antibiotics and oral rinses. But again, because limited debridement may be required in refractory cases, these patients should be referred early on for specialty evaluation. Now, I've mentioned we have both zoledronic acid and denosumab. Of those two options, is there a preferred treatment? Well, these have actually been compared head-to-head in a prospective randomized trial that was published in The Lancet a little over a decade ago. A little over 1,900 patients with mCRPC demonstrated that denosumab had a longer time to first skeletal-related event than zoledronic acid. You can see the hazard ratio here. There was no difference in overall survival or time to disease progression. When we look at toxicity profiles, hypocalcemia was actually twice as common with denosumab compared to zoledronic acid. Osteonecrosis of the jaw, no significant difference and relatively rare across both treatment modalities. When we directly compare these, zoledronic acid IV, denosumab sub-Q, acute phase reaction with the flu-like symptoms, yes, zoledronic acid, no denosumab. Hypocalcemia, more common with denosumab. Osteonecrosis of the jaw can occur with both, neither have a survival benefit. But in general, because of that time to first skeletal-related event prolongation, denosumab is generally the recommended preferred agent by our guidelines. And again, when we look at NCCN to benchmark, bone resorptive agents in mCRPC, denosumab category 1 preferred, zoledronic acid as an option as well. Now, I've talked about this very specifically in the presence of bone metastatic CRPC. What about other prostate cancer disease states? How about castration-sensitive disease with bone metastasis? There's been a randomized trial in this setting. Zoledronic acid did not increase time to first skeletal-related event, not recommended then to prevent skeletal-related events. What about in non-metastatic? We heard about that yesterday from Dr. Cookson, M0CRPC, denosumab, no overall survival benefit, not FDA approved in the setting of M0CRPC to prevent skeletal-related event. Very importantly, we have to understand why we are giving these agents. So in these settings, bone-modifying agents don't improve overall survival, don't prevent skeletal-related event. But what about that issue of bone loss? So we're thinking bone metastasis and also bone loss. There is a role for bone-modifying agents in disease states other than bone metastatic CRPC when we are thinking about preventing bone loss. How do we decide which patients should get that? It gets at the risk assessment for that patient's risk of fracture. This can be quantitated using the FRAX score. This is an online calculator that is based on clinical parameters and DEXA scores. And in fact, treatment to prevent bone loss is recommended if the FRAX score demonstrates a 10-year probability of hip fracture greater than or equal to 3%, or a 10-year probability of major osteoporosis fracture more than 20%. The concept in these disease states is to increase bone mineral density and decrease fracture risk, not necessarily preventing skeletal-related events. The agents that we have to choose from, once again, it's zoledronic acid and denosumab. Here we also have alendronate. But very importantly, when we were talking about in the setting of bone metastatic CRPC, the dosing intervals was every 4 weeks. Here's zoledronic acid annually, denosumab every 6 months. And in fact, denosumab is really the only treatment demonstrated to decrease fracture risk in this setting. What about our AUA guidelines for bone health in advanced prostate cancer patients? Again, coming back to that, the recommended preventative treatments with bisphosphonates or denosumab in patients at high risk due to bone loss. So again, fracture risk calculated using the FRAX score may institute bone preventative therapies with bisphosphonates or denosumab. So what do I want to leave you with in conclusion from this first part of the talk about bone health? When we think about bone health, it's bone loss and bone metastasis. Patients initiating androgen deprivation therapy should be offered calcium and vitamin D supplementation. They should have a baseline risk assessment with a DEXA scan. Patients with bone metastatic CRPC should be offered zoledronic acid or denosumab, with denosumab preferred, to prevent skeletal-related events. When you initiate these medications, beware of hypocalcemia. Calcium should be supplemented and monitored. Beware of osteonecrosis of the jaw. Get a dental baseline exam. Avoid extractions. Avoid ill-fitting dentures. Patients on androgen deprivation therapy should again have that baseline assessment with the DEXA scan, and then should have an ongoing risk of fracture assessment with DEXA scan and FRAX calculations. Consider bone-modifying agents being instituted pending the FRAX prediction of subsequent fracture risk. So let's now shift in the second part of the talk to discussing the role of radiopharmaceuticals in patients with advanced prostate cancer. Again, when we think about bone-targeting agents and bone metastasis, the clinical relevance is that approximately 90% of patients with mCRPC have bone metastasis. Bone metastasis are associated with increased disability, decreased quality of life, increased cost of care, and decreased survival, as you can see from the Kaplan-Meier curve presented here. Now, prior to 2013, when we used that term radionucleotide, it really referred to the agents strontium and samarium. These are intravenous agents without a survival benefit who are really intended for palliative symptomatic bone pain in patients that were not candidates to receive other forms of therapies. They both risk bone marrow suppression based on their mechanism of action, with the side effect profile of samarium slightly more favorable. Strontium and samarium remain options, although rarely used for symptom palliation from bone metastasis. In prior iterations of the guidelines, they were under the term radionuclide therapy. Now, all this changed in 2013 with alpharidin or radium-223. Radium-223 mimics calcium. Its chemical structures are similar and therefore targets bone specifically to form complexes at areas of increased bone turnover, bone metastasis. It functions as an alpha-emitting radiopharmaceutical, so high energy, short wavelength that induces double-stranded DNA breaks in cancer cells. Because of its short range, it minimizes exposure to surrounding bone marrow, minimizing toxicity. It minimizes surrounding tissue damage, and there are no contact restrictions during treatment. It's administered as an intravenous infusion, given once every 4 weeks for 6 total treatments. Treatments are quick. They can be done in the office after special setup. Radium-223 is excreted through the GI tract, so patients can get some GI toxicity, but the key AE to be aware of is lymphocytopenia. Despite its short wavelength, still 20% of patients have been reported to have grade 3 to 4 AEs, so a CBC should be checked at baseline and before each dose. This is the phase 3 randomized trial known as the ALSYMCA trial, published in the New England Journal of Medicine, which led to its FDA approval and subsequent place on our guidelines and in our management paradigm. A little over 900 patients with symptomatic bone metastasis, no visceral metastatic disease, mCRPC, either before or after docetaxel. Very important that we understand the eligibility criteria because these have become the patients for whom radium-223 may be utilized by our guidelines. They were randomized to radium or placebo with a primary endpoint for a bone targeting agent of overall survival. And what this trial demonstrated was that radium-223 did significantly prolong overall survival. You can see here by about 3.5 months compared to placebo, highly significant hazard ratio. It also prolonged time to first skeletal-related event, hazard ratio 0.66 from 9.8 to 15.6 months. Over a variety of different subgroup analysis, the benefit of radium-223 was maintained, and in particular, it was maintained both among patients who were chemotherapy naive, as well as among patients who had previously received docetaxel chemotherapy. A number of other secondary endpoints, primarily biochemical, were assessed: PSA levels, alkaline phosphatase, and again, radium-223 improved the outcome of these endpoints compared to placebo across patients. When we look at the safety profile, it was well tolerated. In fact, the number of AEs was lower with radium than placebo. There was no clinically meaningful difference in grade 3 to 4 adverse events or treatment discontinuation. And in fact, quality of life was significantly improved in more patients on radium than on placebo, as measured by the FACT-P instrument. So prior iterations of the guidelines nuanced who patients would be eligible for radium: good performance status, symptomatic bone mets, mCRPC, no visceral mets, pre-post docetaxel, may be offered even for patients with poor performance status when that poor performance status was directly related to symptomatic bone metastatic disease. I think our most recent iteration of the guidelines has simplified and clarified this to make it very user-friendly in clinical practice. Clinicians should offer patients radium-223 who have symptoms from bone mets in mCRPC, no visceral metastatic disease, or lymphadenopathy greater than 3 centimeters. Again, when we look at our NCCN guidelines, very consistent criteria. Patients may be chemotherapy naive, no prior hormone therapy, radium-223 if symptomatic bone metastatic disease. Patients may have had prior docetaxel chemotherapy. If symptomatic bone mets, may be offered radium-223. May have had prior novel hormonal therapy, no prior docetaxel. May have had both prior docetaxel and novel hormonal therapy, radium-223 if symptomatic bone metastatic disease. Where is this going next? Treatment selection, as we're hearing more about the number of different options, is going to be critical. Some studies have demonstrated on secondary analysis that perhaps some biochemical parameters, hemoglobin, alk phos, performance status, LDH, may be utilized. As with many areas of prostate cancer, the potential remains for molecular biomarker stratification for treatment selection. What about retreatment? This phase 1/2 trial published by Oliver Sartor and colleagues, 44 patients, demonstrated the safety of retreatment with radium-223 in patients for a second 6-cycle course. What about combination therapy? There's lots about this, and we heard about triplet therapy in other agents yesterday. Well, this was a phase 3B early access trial that looked at combination therapy with radium. So this is importantly, because of its design, not a prospective randomized clinical trial. It evaluated the experience of patients who were receiving radium along with the various other therapies, as you can see here, post hoc exploratory analysis only. And what they found was that the safety profile was similar in combination therapy, and that in fact, patients had better overall survival when they were receiving combination novel endocrine agents or combination denosumab with radium-223. So very appropriately, these type of hypothesis-generating data were then tested in a prospective randomized clinical trial, the ERA-223 trial, which randomized patients who were receiving abiraterone to receive radium-223 as well. A little over 800 patients, follow-up just about 2 years. The primary endpoint of the trial was symptomatic skeletal event-free survival. And what the trial demonstrated, interestingly, was that adding radium-223 to abiraterone did not improve symptomatic skeletal-related event-free survival, but actually more patients in the combination treatment arm experienced a fracture, and in particular osteoporotic fractures. And therefore, the recommendation by our guidelines is not to use these agents in combination because there's no benefit to the primary endpoint of the study and increased fracture risk. Now, very interestingly, only 40% of patients in that trial were on denosumab or bisphosphonate. So remembering back to the first part of our talk and AUA guidelines, these patients with bone metastatic CRPC should have been treated with that. There are a variety of different other combination studies that have either completed accrual and are beginning to report or have completed or are still ongoing. So I think there's lots to come on this. So what do I want to leave you with in conclusion from the second part of the talk? Radium-223 represents a standard management option for mCRPC patients with symptomatic bone metastasis in the absence of visceral mets or lymph nodes greater than 3 centimeters. It can be used either pre or post docetaxel. It's well tolerated. It improves overall survival. Beware to monitor CBC counts during this. Future directions will include patient selection, combination therapies, perhaps pending clinical trial assessment. And of course, we need to assess the impact of this type of bone targeting agent as our novel imaging modalities that we heard about yesterday and enhanced lesion detection continue to improve. So with that, I want to stop. Thank you again very much for the opportunity to be part of the faculty. And I will introduce our next speaker, Dr. Alicia Morgans from the Dana-Farber Cancer Center.